Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator.
Priscila Meneghetti graduated from dentistry at the Federal University of Santa Maria in Brazil in 2005. She's a specialist in prosthodontics at the University of Bauru, USP, and a master. She holds a master's degree in restorative dentistry from Brazil as well in 2019. She's currently a Ph.D. student of the restorative dentistry at PUCRS. She's a research scholar and an adjunct clinical professor in the Department of Biologic and Material Science and Prosthodontics at the University of Michigan in Ann Arbor. Our research line is in innovation and digital technologies. She's a member and fellow of the International Team of Implantology, ITI, and a co-director of the ITI study group in Porto, Alegre. She's an ambassador for Women Implantology Network in Brazil, and also part of the Straumann Group project to engage and inspire women into implantology. Dr. Priscila Meneghetti, it's a privilege, and we are really, really honored to have you in Dental Webinar Series today.
Thank you, Uvoh, for inviting me. It's a pleasure to be here with you and talk about digital implantology, digital workflow in implant dentistry. I'm Priscila Meneghetti, as you said, and it's a pleasure to be here talking to you and talking to the Healing Hands Health Society. It's a great work you are doing, bringing a lot of good dentists to let all the people of the world know about it. So I will not repeat what you just introduced me, but I'm here at University of Michigan as a PhD student, and I'm working directly with the grad pedi residents, doing all the digital planning. So when I came here, I think about the digital, there is a phrase that only thing that is constant is change. So we cannot stop, and we are very glad that our profession it's evaluate the evolution of digitals in our profession is so good, and we are, of course, we cannot forget about the analogical way, because you have to know the basis. But working the digital, it's every time we are learning something, so we have to be ready for it. So the digital workflow, how can we incorporate the digital dentistry in our clinic? So it can improve our diagnostic with the better images, with the scanning, the CBCT. It can help us in the planning of our patient. It helps also in the teamwork, how we can talk to the other specialties, helps with the communication, also with our team and with the patient, help us design the best treatment choice. And I think for the patient, we can give them a better experience. So today I'm going to talk about the digital workflow, the virtual implant planning, and I will discuss a clinical case that we can put all this together and how can we improve our results. in our cases. So to start to talk about digital, sometimes we have to know some concepts. And the ACP, the American College of Prosthodontics, they did a paper, like a glossary of digital dental terms. So to let us know what it means. So CAD-CAM, so the CAD, it's like the computer-aided design, where is like the software that you're gonna use to work. And the CAM is the computer-aided manufacturing, that we can use the computer software to control the machine tools that we are going to manufacture our workpieces. The STL is the standard tessellation language. It's a native file format that can bring us a 3D image of our object that we scan. So it brings us the surface geometry of an object, but it's like not color. So if you have here a picture, we have like, I put a piece of the scan and they give us the mesh. So the STL, it's actually a lot of triangles, that when you have like more triangles, you have a better image. And sometimes if your triangles is not so good, your image is not so good as well. We have also the PLI. It's a polygonal mesh that instead of just give us the surface, they give also the color and texture of an object. And we also can have like the OBJ, that is a simple data format file that represents the geometry, just the geometry of a 3D object. And the DICOM file, it's a digital image and communications in medicine that will integrate all the scanners, servers, printers, and workstations, and can get all together the informations of the patient. So now, instead, when you do the CBCT, instead of you have like a image in a paper that you can print, you can have a 3D image of your patient, and then you can have you can work on it in a better way than just like the file in a 2D image. And we have also a scan body that is a scannable object that you can translate and transcribe the position of the implant into a digital file, and then you can use it to do the final restoration. So we have like the final position of the implant. So when we're going to use the scan body, we have to know, like, we can scan the implant. So each implant has their own scan body to a correspondent implant. And also we can scan the abutment. So we have to have the scan body for these abutments. So the digital workflow can help us to improve diagnostics, help us to the case planning, and also the surgical and prosthetic execution. Bring us more predictable outcomes, and also bring like more benefits for the patient experience, for the dentist, and also for our business. So the patient can have like more safe, it's more predictable to show the benefits, the results, how can we improve our case. The dentist also bring like more predictable cases. You can like run in a way that you can see how can you obtain a best result. And for the business, also it's like you bring innovation for your clinic, more technology. So it's also better for your business as well. So working with implant therapy with digital, we can go for the single cases, like put an implant, partial or full cases rehabilitation. And then we can start this digital workflow with the data collection. So we can get like the photos, the CBCT, the scan, and also we can get the CAD/CAM, the second step, and then the third step is the implant placement and the surgical protocol as well. So the data collection, we can start with the photography, then intraoral scan, and then the cone beam computed tomography, the CBCT. So I will introduce like the case. Instead, I'm going to put everything together in this case. So the photography, it's very important, like not just to take pictures of the smile, but take pictures of the face, extraoral images and intraoral. So because we want to know the midline of the patient, if the patient has some, if it's like right or no, if they have some deviations. And we can take the pictures based on the DSD, the Digital Smile Design, proposed by Christian Coachman. So we have to take pictures, the face with the retractors. And then we can start design in a 2D way, the midline. Then we can propose like a new smile design. So this patient, she has a missing number 10, and she used Invisalign orthodontics, and she was referred here to Peru to Dr. Rafael Siqueira, and we started to plan this case that is like not to put an implant where the bone is, but she is planning to do some veneers in this case. So when we saw her pictures, sometimes we set patient to smile and they give like a shy smile. But when you start to talk with the patient, and then you can realize that the patient has a high smile line. So this is a very complex case. But we can see the level of the gingiva, how we can improve it. And then here in this case, we can see that we can do gingiva crown lengthening on her right side. So we can measure based on these rules that we can calibrate before. We can see how much we can remove of gingiva and bone. And also, when you take some pictures, we can take the occlusal view. We can have pictures of the 12 hours photo. So we can like analyze in always how can we improve her smile. And then here we can do like a simulation in a 2D. But we can see here the level of the margin that we want the final restoration. In this case, here also we can take some pictures of where we are gonna like put the implant. We can see how thick is the gingiva, the space that we have. But in this case here, we see that we have like enough space for the tooth. But when you took the X-ray, here a periapical X-ray, you can see like the roots are a little bit tilted, and like it's very hard to see. It's very straight, like very small space for the implant. So the purpose for the surgery, Dr. Rafael Siqueira is wonderful for this case. She's doing like a static crown lengthening for number 4, 5, and 6. and put an implant placement on number 9, and also with a GBR. So here we have some evidence for this approach. And when we see the ITI SEC classification, so we can see that this is a simple or advanced or a complex case. So this is a very used checklist that you can use to use like as a risk management for each case. And in this case selection, we can see if the surgeon has the skills to do the case, and also it's a good way to communication with the colleagues that we are gonna like to restore the case, and also with the patient. So we can evaluate the expectations, and we can tell the patient how difficult is this case, and of course that you have to do the best for a good result for the patient. So in this case, that is a single tooth restoration in the anterior zone. We can have, we have a high static risk because she has like a lip line with a full exposure of the mucosa margin. And also in this case, if you evaluate the surgical space, is very restricted. And we can also have to evaluate the patient expectations. So going ahead with this case, so since we have like the photograph, now we can get the intraoral scanning that we have like a lot of scanning in the market, but at the same way, if we don't have the scan, we can take like the impression, and then we can scan in a lab scanner. And the scan will give us a STL file or a PLI or a OBJ. And also if like we're gonna scan with a tree shape, they give us a DCM file that is like the closet, but we can have exporting as a STL, and then it's an open source file. So we have to take the intraoral scan. So here in this case, we took like with a tree shape. So we have color scanning that you can take also the upper and lower and the bite. And here I bring some tips how to improve our scanning. So you always have to remove the light reflector. We can dry the area and the mouth. A very good tip is to use Optagrade. So sometimes the patient has like a cheek or don't have like a big mouth that can open to have a good scan. So we can use Optagrade to scan. We can position the patient in the chair in a good way that is like more ergonomic for us. Try to have no saliva, and also avoid metals or amalgam restorations, crowns, metal pins. In these cases, we can use a power. So now the new scanners, it's like more easy to do this. And also we can use like the scan technique for full mouth rehabilitation according to the scanner brand. But actually we can start like for the occlusal, go to the palatal, and then to the, then you can go to the buccal part of the mouth. And sometimes it's the opposite. But like a good scan will give me a good model. It seems like if I take a good impression, I will have a good model as well. And here for a guide surgery, it's always important that you have like, that you make a complete full arch scan. Also include the palatal arch on maxillary, as well as much border and distal extension as possible. And we have to do the scans in occlusion. And also remember that if you get the CBCT, it's better if you get out of occlusion. So here we took the CBCT of the patient in an open bite. So the CBCT will always help us to identify pathologies, how was the vital anatomy structures of the patient, adjacent teeth, or if they have like implants, and we can see the bone quality and the quantity of the bone. And also in some cases, we can check the mucosa. So some tips for the best CBCT acquisition, it's like we can get like a calibrate CBCT scanner. We can took the open bite scan during scan. Free occlusal surface, it's always help to planning. The appropriate FOV, the field of view for each indication. So if it's a single implant or a full arch, and the appropriate voxel size, it's the resolution versus time exposure. So this is more for the technician to know about that. But we can always remove artifacts if it's possible, because this interferes a lot in the quality of the CBCT. Because when we have like too many artifacts, it's very difficult to align the DICOM file with the STL, like in this image. So here I'm showing like it's like the same case. So if you don't have a good alignment between the scan and the tissue, it's very hard to get a precise guide. And also we have to ask the patient to not move, to be steady, not move during the CBCT, minimize the background noise. We can ask him to take the tongue away from the palate. And also a good way, it's like the soft tissue separation. So we can use a retractor, or we can use some cottons. So January in 2008, he reported a paper and I studied, because in this case, we can see here in the slide that they don't remove, that don't get away the lips. So we cannot see where is the soft tissue. So this is a good tip to the next situation. And here in the second point, if you're going to the second stage, we need to get the CAD software. So the software, we're gonna do the digital planning, we have to combine. So actually here we have like different softwares in the market. We have some softwares that is free. Some of them you can just like pay a fee for export the guide. And some softwares like TreeShape and Co-Diagnostics, you have to buy the software. So the software will give us to combine the DICOM and STL file. So we can start like, we will have like a prosthetically drive implant position. We will design the implant position in the right way. And also we can design the surgical guide. So here in this case, if I went to the software, I design the smile that I want for her. So we can do the digital WhatsApp, the diagnosis setup. And this, if I see here, when I design the teeth for her, I can see that my lateral number 10, it's covering a little bit of the gingiva. So probably here we have to do some manage this situation, and I will show to you. So my implant, the important thing here that my implant will be prosthetically driven. And here in the software, I can align very well. Since I have the CBCT with no artifacts and with like the occlusal free, I can align very well the scan with the CBCT. And then I can try to position my implant in the best way. So here it's nice in the software because we can change the implant, we can choose the best implant. So here when I try to plan a Straumann BLT 3.3 millimeters, I can have here the safe zone, and I can see that my safe zone, it's invading, like it's touching the roots of the adjacent tooth. So it's like a very strict case and very difficult. So that's the digital bring us more safe and more security, like to go ahead in this case. So here I will not, like, of course, put a BLT 3.3 because it's very near to the roots. So we change for a 2.9 BLT Straumann. There is a narrow neck implant, and also here we can check how deep you are going to put this implant. So here you can measure for the future crown from the CAJ that I want, how deep I will put this implant. So some article says about 3-4 millimeters apical to the planned prosthetic margin. And then we can see here that you have to remove a little bit of bone in this case. And also I can have a this cross-section view. So with the 2.9 implant, now I have a safe zone, like more predictable for this case. And then we can go ahead with the planning. But if we don't have digital technology for evaluating this case, you can see that like it will be very hard to put like a free hand. And then we can do like a good mistake here, like a huge mistake. So for this case, we can use like just a pilot drill, like it will be not full guide, it will be a partial guide implant placement. So the software give us like a protocol, the drilling protocol. So I can say here that we are going to use like a 2.9 millimeters BLT implant, 12 millimeters. And we are going to use the T-sleeve. And they also say for us my guided drill, so it will be a long drill. And we are not going to use a cylinder handle because it's just like for the first drill. So here you just have one chance. So it's nice if you can do, like you go with the drill for a little bit, and then you take an X-ray, make sure you are in the right place, and then you can go ahead. And they also give us, the software give us a PDF protocol that you can have some pictures of what are you planning. So it's nice to print this or put in a screen during the surgery to check. And then here we printed the guide in a 3D printing. So in this case, we cannot like do a flapless surgery. So guided is not like being flapless all the time. Sometimes you have to open the flap. So our guide will be a teeth support. So bring us more accuracy. We put like some verification windows to check the fitting of the guide. And then we manufacturing this guide in an additive way now with a 3D printer, but we can also do with a milling machine in a subtractive way. And it's very important to check all the situations because you can have some errors during the planning. So the data collection, like the CBCT and also the scan, has to be very accurate. How you are going to transfer this. So you have to have like accuracy, CBCT, accuracy alignment of the CBCT and STL, like less artifacts, the anatomical parts. You have to make sure that everything is right. You can choose your type of support, and have to be like teeth, bone, or mucosa. So for different cases, in this case, that is a teeth support guide. It's better or more accurate. So also the drilling distance and the number of teeth support, all of this interferes in the accuracy of your guide. So here, in the day of the surgery or before, we can check the fitting of the guide, if it's fitting well. So for this case, in the day of the surgery, Dr. Rafael, he started with the crown lengthening. So he did the crown lengthening of this teeth. And here we also use the mesh mixer, that it's a free search software that is very useful, and I recommend everybody to download, because in this case, since we have the planning, we know where you want the provisional. So we design here like a guide to help us to give where is the to give us where is the CAJ of our future tooth, and then we print like a guide, and also help us to do the provisional for the second stage. So when they start to do here, they did a facial oriented crestal incision. And here we use this because if we put the implant where is the bone, our tooth will be too short for this situation. So we can use this guide to help us to measure how bone we have to remove before put the implant. So in this case, we use a spherical burr to remove the bone and keep like 3 millimeters deep from the future margin. And then we can put our implant. So here, just to quickly remember, when you use this implant, we have like a cross fit section, and we have like this, we have these points, and these points has to be to the buccal side. So here, after when the patient came to remove the suture, and this is the situation. So the patient, like when she come back for the second stage, the patient is still have a depression. And then he did the second stage, another flap, another technique to increase the soft tissue. So this is not like my part, but sometimes the names of the surgery, but he did like a row, or he take gingiva for the palate and bring to the buccal to increase the buccal thickness of soft tissue. And then here we expose the implant. Here is the X-ray with the provisional abutment. And then on the second stage, we also capture, and so we 3D printed the provisional, and we are using the temporary abutment to capture. So we capture in the mouth, and then here in this situation, I think when he put the implant, it was not very, the points was a little bit tilted, and then we have to remove a little bit of the abutment, and then we capture the provisional, and then we install in the mouth, and after the surgery, we can see how it was, and then now we have to wait for the healing. So here is the final X-ray that you have of the patient. So the patient also come back after this situation. When she come back to remove the suture, we did a scan to do like a Essex for her to keep the mouth in the position, since she removed the Invisalign. And here, after I think 10 days or 2 weeks, she removed the suture, and now you have to wait for the final healing of the tissue. And then this patient, she will go to the Prosthodontics to make the final veneers and the final crown. So here is the final. So we can see that the quantity of gingiva that we obtain in this case. And so if you ask me why guided, so I think the guided bring us a predictable results. So the virtual planning enables the digital predictability, safe, and also more efficient. So less time of surgery, less time in the chair. It's like more, also in this case, that is very hard. We have like more efficient, and also more safe for the patient. We know what are we going to do, and we know how can we obtain the results. And here is the final X-ray. So the digital workflow for implant treatment has increased accuracy and improved diagnostics, treatment planning, and surgical execution in dental implant placement. And so we have like successful treatment for a happy patient. So I'd like to thank you for everybody that is here, but also for my team here at University of Michigan, Dr. Gustavo Mendonça. He is my PI here, and I learned with him all the digital to work with 3D printing and all the softwares. So when I arrived here in Michigan, it was like 1 week before the lockdown. So I have like some months with online classes, and then I started learning how to work with mesh mixer. And then when I come back to school, working with grad ped residents, I can start to learning to put in practice all the digital planning. So it's very nice when you have a prosthodontic point of view and also the surgical point of view together. So that's we call the teamwork. So Dr. Rafael Siqueira, he's also a Brazilian, and we did a great work here in University of Michigan. And also I like to thank you, Dr. Lee. He's like he's a new faculty here now, and I learned a lot of him with all the digital technologies. So thank you, Uvoh. Thank everybody. I'm here to answer some questions if you have. And
okay, very nice. Thank you so much, Dr. Meneghetti. That was, I mean, we have to go back and watch that again and kind of, and it takes, you know, like you said, the mesh mixer is a free software, right?
It's a free software.
Yes,
that's
so
right.
I think, you know, go on. I'll share it. I'll share the link again on Facebook, so you can go back, and you need it. You need to play around with it. You need to get your hands on it. You need to move some teeth. You need to. So there's already like denture, you know, like samples you can move, try it in, you know, tilt it. It takes getting used to.
And also mesh mixer, they give you can study your case. Like if you don't have a software, if you don't have the scan at your clinic, it's very nice software that you can show your patient what you can do. If you have enough space, if you don't have, you can, there is a free library of teeth that you can download in the software. So it's not a dental software, but you can do a lot of things with mesh mixer.
Okay.
So of course, in the beginning, it's a learning curve. You have to learn how to use it. But
yes,
even though when you learn it, you cannot live without. Even if you have like softwares that you pay, like even if I use like TreeShape or Sirona, Cerex software, it's very helpful. Very helpful.
Yes, I believe so. Anyway, thank you so much. And this gives you a tip of the iceberg in terms of what is possible with digital technology, and that is where the world is going. Hopefully, we're planning some hands-on exercise. Maybe Dr. Meneghetti can come with us. We are going to be in Nigeria very soon, where we're going to do some hands-on with a computer, with a scanner, intraoral scanner, and just come up with how to manufacture do a full mount digital wax up. So I think that would be a good exercise. So how to do a digital wax, a full mount of crown. So we already have like a sample patient. We already have the scans. And if you have your mesh software, then we can all practice that. And if Dr. Meneghetti will be free to travel, I know there's COVID and all the restrictions, then it will be, we'll do a hands-on. It's going to happen in the University of Benin next year by God's grace. I don't know when yet, but I'm hoping and pushing and looking for money to make sure we can buy our tickets and come back.
For sure, it will be a pleasure.
All right.
But so also online, we can teach. It's very nice software.
Yes. So there are two questions here. Is that after generating the surgical guide, is it necessary to do a disc WhatsApp of? Is it after generating the surgical guide? Is it necessary to do a diagnostic wax up to see how the guide will fit in the patient's mouth? I don't know if that question.
I didn't. Let me read here. Generate the surgical guide. Digitally, it's necessary to do a diagnosis. Actually, will fit in the patient's. Actually, you can try. You cannot know digitally if it will fit or not.
Yeah.
But they give us like, how can I say, a distance, a relief of the guide in the mouth.
Okay.
So you cannot like do the guide very tilted, like very, how can I say, you have to get some distance, but it's nice if you can try the guide before the surgery. And that's why we do the windows.
Yes.
To check the fitting of the guide. And also you can relief sometimes, but you can do the relief in the software.
Yes. Yeah.
And they give us like
the question he was asking was about.
I don't know if I understand
about the digital wax up. I mean, it's a little. The question is
actually you can print the model with the digital wax up, and then you can do like a mock-up in the patient's mouth. You can do a mock-up.
Yes, I think that's
so you can print the model with the tooth that you want, and you can do like a mock-up with PVS.
Yes.
And acrylic resin, or not the other kind of acrylic resin, or also you can 3D printing, like a setup, and then put in the patient's mouth. There is a lot of ways to do it, but for sure you can.
There's another question here about Dr. Akinyemi asking about is it the mesh, the mixer, is it tied to any particular implant system?
No, actually, mesh mixer.
It just gives you anatomy.
Like you cannot use implants in the mesh mixer. Don't have just like tooth and this kind of things.
Yes.
3Shape, they give you the library. So if they don't have the library, you have to download the library for a lot of brands of implant.
Okay.
Also, Blue Sky Bio, they have like, or you, if they don't have the brand, you can use like a personalized implant, and you can put like the measures that implant has to planning.
Okay, all right. Priscila Meneghetti graduated from dentistry at the Federal University of Santa Maria in Brazil in 2005. She's a specialist in prosthodontics at the University of Bauru, USP, and a master. She holds a master's degree in restorative dentistry from Brazil as well in 2019. She's currently a PhD student of the restorative dentistry at PUCRS. She's a research scholar and an adjunct clinical professor in the Department of Biologic and Material Science and Prosthodontics at the University of Michigan in Ann Arbor. Our research line is in innovation and digital technologies. She's a member and fellow of the International Team of Implantology, ITI, and a co-director of the ITI study group in Porto, Alegre. She's an ambassador for Women Implantology Network in Brazil, and also part of the Straumann Group project to engage and inspire women into implantology. Dr. Priscila Meneghetti, it's a privilege, and we are really, really honored to have you in Dental Webinar Series today.